our first question, we will ask about the Professor Malard. Doctor, we know you are a leading authority in microbiome research, especially its role in the transplantation and the immunotherapy. So first, we want you to share with us is, could you share the latest evidence and the translation perspective of the microbiota modulation in preventing and treating transplant-related complication like the aGVHD and the infection? And the second we want you to share is from the perspective of the gut immune extras. How can we understand and optimize the peri-transplant support care to improve the long-term patient outcome? Thank you so much, doctors.
So, thank you for inviting me today to all these very well distinguished speakers and my colleagues and friends from China. Very happy to be there. You raise an important, very important subject, and it was just presented by my colleagues right before. The result from the phase 3 RS study that evaluated microbiotherapy for the third-line treatment of acute graft-versus-host disease. So in this phase 3 study, we're able to show that for patients with GI involvement, so as you know, this is the patient with the most severe involvement for acute graft-versus-host disease that failed both steroids and ruxolitinib. We performed this microbiotherapy using these drugs, Xerviteg or MAD13. We performed 3 FMT 1 week apart, and we're able to achieve a novel response rate above 60%. And what is very important is that we did not provide any additional immunosuppressive treatment, and we are more in an immunomodulatory approaches, and it was well tolerated, in particular regarding the infectious side effect. It was not higher compared to other patients that received other treatment. And what was very important, it was some sustained response because patients remain in response at day 56, in particular patients that were in complete response remain in complete response, highlighting that we have some long-term effect without any maintenance therapy. So now with these drugs, we're aiming for an approval in Europe this year, but we expect that we'll be able to use these approaches in other countries around the world, including in China. So this is for the curative approaches. We are now also moving for more prophylactic approaches. So we have this paper that was published by Amin Rashidi 1 year ago or 2 years ago in the GCO, where he evaluated FMT after induction chemotherapy for acute myeloid leukemia or allogeneic hematopoietic cell transplantation. It was a negative study, but the primary endpoint was to assess all infectious events rate. And of course, with the microbiotherapy, you may have an effect in bacterial infection, but it's less expected to have an effect on the viral infection. So at the end, it was a negative study, but maybe there was also some issue with the primary endpoint. We are currently doing a multi-center study across Europe, so and we plan to include almost 400 patients, who will be the biggest phase 3 study evaluating microbiotherapy, and it will be some prophylaxis with some patients that are going to take some pills 1 week before we start the conditioning regimen. We stop, and they will take them again around at neutrophil recovery up to day 100. And the primary endpoint this time will be to improve the overall survival. So this is very ambitious to look if we can improve overall survival just by microbiotherapy, but we really think that it will be the next steps. So all the improve. So sorry, I have some internet issue. I really truly apologize. I don't know what's happened, but we're at the end of what I was explaining, and to show just in 1 minute to finish that we have now more and more data that explain that there is not just a correlation between the microbiome, but truly some mechanistic, and that the microbiome which modulates the immune system through the short chain fatty acid, the bile acid, and so on. So we truly expect that it will change the field of hematopoietic cell transplantation. So sorry again, and yes, now I, Dr. Jiang, I will let you.